A very good afternoon. I'm Dr. Gayatri Kamath, the Additional Director at Fortis Hospital, Banagata Road, and I'm from the Department of Obstetrics and Gynecology. A very good evening to all gathered here. So, today I'll be talking about a very common topic, which is hysterectomy. Now, what is hysterectomy? Hysterectomy refers to removal of the uterus. Now, why do we need to remove the uterus at all? There are certain indications when the uterus needs to be removed. Now, if we look at in 2024 versus say 20 years ago, the indications for hysterectomy were far too many because there were no medicines, there were no revolutionary treatment available in those days. So, any woman after the age of 40, if she would come up with heavy menstrual bleeding, she would be subjected to removal of the uterus, what we call a hysterectomy. So, today in my 20-minute talk, I would like to highlight the need for doing a removal of the uterus. What are the different ways the uterus can be removed? And are there any options available for removal of the uterus? Obviously, as healthcare providers, we would like our patients to have something as minimalistic as possible. So, we need to get this point clear that before offering a woman removal of the uterus, are there any other options which will work out for them? So to know that, we need to know why does one need to remove the uterus. Now, as we all know, uterus is an organ which keeps the baby in its womb, and the delivery happens after a good 9 months. So, primary function of the uterus is managing the process of pregnancy and delivery. Now, we also know that women go through menstrual cycles, which happens every month. And in normal menstrual cycles, what typically happens is they get their periods cyclically and they bleed for a fixed number of 3 to 5 days. Now, some women tend to have certain menstrual aberrations, which usually starts somewhere after 40. What typically people experience is heavy menstrual bleeding. Now, if the period is normal, then the bleeding lasts only for 3 to 5 days. Women never become anemic because of loss of blood, and they tend to come around easily after the period. Now, in women who have heavy menstrual bleeding, the bleeding goes on for days on row. Their hemoglobin begins to drop. They feel terribly weak. They tend to feel giddy. They have blackouts. And then that calls for an intervention because that is not considered to be normal. So, heavy menstrual bleeding is one of the reasons people come up to us and say, look, doctor, I've been having very heavy periods. Most women who have heavy menstrual period need not undergo a removal of the uterus because the problems of heavy menstrual bleeding is usually due to a deficiency of these progesterones. So, by giving progesterones in the form of tablets or in the form of a device, what we call Mirena, which is inserted into the uterus, most women can overcome their problem of heavy menstrual bleeding. But if despite these medications their heavy bleeding does not come around, or they are unable to tolerate the medicines, or if the Mirena, which is a novel therapy where progesterone is released through a device called Mirena, which is inserted into the uterine cavity, if this is rejected or the Mirena falls off, then one may have to think of other options. So, one of the common reasons is heavy menstrual bleeding, which is not responding to the usual medical line of management. Then comes the other condition called fibroids. Now, fibroids are fairly commonly seen in the present population. There was a trend when we were telling that mostly 20% of Indian women can have fibroids, but now in the present day, we see as many as 50 to 70% of women can harbor fibroids, So that is something we need to remember. And most fibroids, we need not subject them to a surgery at all. If the fibroids are too large, if the fibroids are encroaching on the cavity of the uterus, or if the fibroids are putting pressure on the neighboring organs such as the urinary bladder or the intestines or the ureter from where the urine drains from the kidney to the urinary bladder, then one may have to resort to a mode of surgery. So, first problem is heavy menstrual bleeding, second is coming to fibroids, then coming to other not very common conditions like cancer of the lining of the uterus. Thankfully, cancer of the endometrium is a very rare situation where the lining of the uterus begins to harbor a malignancy, and such women may have to be resorted to a removal of the uterus. So, that is called a hysterectomy. So, by and large, these are the common reasons why women have to be subjected to a removal of the uterus. Now, how does one remove the uterus? Say 25 years back, the only methodology was to cut open the abdomen like a cesarean section and then remove the uterus by a big scar, which is almost like a 10 centimeter scar, and that would be the way forward, say 20 years ago. Now, with medical field revolutionizing, we have better modalities which are available. One of them is the laparoscopic mode and the other one is the robotic mode. In the laparoscopic mode, small keyhole scars are made on the abdomen, and then the supports of the uterus are dissected away and the uterus is removed from below, that is from the vagina. So at the end of the surgery, women will have small 1 centimeter, less than a centimeter scar, maybe 3 or 4 of them on the abdomen, and the recovery path is pretty good. So why don't we do any more of abdominal hysterectomies? Because with big incisions come big pain, and the recovery path is far more longer. So, how is laparoscopic hysterectomy done? It is done under general anesthesia. So, the woman is oblivious of this. The patient is completely under anesthesia. She would not be aware of what is happening around her. And then the surgeon starts the procedure. In a laparoscopic surgery, a telescope is placed inside the abdomen, and then the abdomen is distended with a large amount of gas, and then certain other ports are put inside the abdomen, and then we disconnect all the supports of the uterus and then remove the uterus from below. So, this is the classical procedure of a laparoscopic hysterectomy. Now we have robotic technology, which is the current trend towards hysterectomy. Now, what is superior when compared to robotic versus laparoscopy? Now, the technology of robotic is such that the robotic camera has two eyepieces, so that there are two lenses which are getting into the abdomen of the patient. So it's almost like the eye of the surgeon is inside the abdomen, and the robotic arms have a 360-degree mobility. So it's almost like the hands of the surgeon are inside the abdomen of the patient. So, with such clarity in terms of its vision and with such dexterity in terms of its mobility of the arms, the surgeon finds it easy to go ahead with surgery, and the blood loss is very minimal. The tissue dissection is just the right amount, and the chances of injury to neighboring organs is very, very remote. That is why now it is robotic surgery which is taking up because of the technology and the advantages which come over laparoscopy. Now, together, laparoscopy and robotic surgeries, we call it as minimal access techniques because we are doing very small scars, just like laparoscopy, even in robotic, they are very small scars, and the recovery path is very good. So, if a lady has to undergo hysterectomy, generally she remains in the hospital for 1 to 2 days and then she is discharged on the third day. After she goes home, she can resume her normal activity gradually. Obviously, after having gone through a major surgery of this, though it is a major surgery, she tends to recover fast because of the minimal access techniques we adopt these days. She is supposed to resume her normal work slowly and gradually. we need to understand that if any patient is going through surgery, she needs to be briefed about how the surgery goes on and what are the risks and complications while doing surgery. Any surgery, there are risks associated, and that is why we need to offer surgery only when other conservative options fail. So, what are the risks with hysterectomy? Any surgery, you have a risk with bleeding, you have a risk with infection, you have a risk with injury to neighboring organs, and you have a risk of landing up with blood clots. And the last and remote complications are these anesthesia related complications. So when you're doing surgery, you're cutting through tissues. Whether you do minimal access or open, there is going to be some amount of blood loss. Just like I mentioned, the blood loss reduces as the technology advances. With open surgery, there's that much more blood loss because your incision is so big. In laparoscopy is less, and in robotic it is the least because your tissue dissection is pretty much precise. Then coming to infection. Infection can happen because our skin harbors a whole lot of bacteria. Usually, before any surgery, we do a lot of prep on the abdomen where we clean the abdomen, remove all the bacteria. Yet, there can be some bacteria entering from the skin inside the abdomen and causing infection. And also, we tend to put a catheter to drain the urine from the urinary bladder, which helps is in the initial post-operative period so that the patient does not have to get up and pass urine. This catheter itself can introduce the organisms from the vagina into the urinary tract, so you can have a tendency for urinary infection. So, to prevent that, by and large, most of us adopt enough precautions and we escape infections. But still, some people can land up with urinary infections and skin and superficial tissue related infections. Thankfully, with minimal access surgery techniques, the chances of infection is also very, very low. Then coming to injury to neighboring organs. Now, if a lady has never been operated in the past on her tummy, the chances of injury to neighboring organs is very, very remote. This can increase if a lady has had previous surgeries in the past. When a lady has surgery in the past, some of them, not all women, some women can have the uterus stuck to neighboring organs, and when it is densely stuck to neighboring organs, while the uterus is separated from the neighboring tissues, there can be injury to neighboring organs. So one needs to exercise precaution, and we generally follow, during surgical principles, we ensure that this is taken care of. But there is a remote chance of injury to neighboring organs like the urinary bladder, the ureter, the intestines, etc., which we may be mindful of, and we need to counsel patients who are undergoing surgery. Women who have had multiple cesarean sections, women who have had endometriosis. Endometriosis is another indication where we may have to resort to removal of the uterus, tubes, and ovaries. Such women tend to have a lot of additions and they have a higher chance of landing up with injury to the neighboring organs. Then coming to blood clots. Why do women develop blood clots? When anybody is in a fixed position for a very long time, the blood can stagnate in a particular place and can develop blood clots. So to prevent that, we tend to make the patient ambulant immediately as fast as early as possible after surgery, and we tend to hydrate them well, and some of them are offered blood thinners to prevent blood clot formation. So these are usually the risks and complications very rarely one may encounter during hysterectomy. So, how is the recovery path after hysterectomy? Generally, with minimal access techniques, there are people who recover so fast. I've had women who had operations as early as on a Tuesday and have gone reporting to work as a principal of a school by Friday. Some of them have gone dancing for a party as well. But I should tell you that the healing process is best when the person is mentally tuned to the process. Never rush with the procedure of surgery. Before going for any surgeries such as a hysterectomy, you need to weigh the risks and benefits. You also need to assess and see whether there are any other alternative options. But if that is the option, you will have to be mentally prepared for it, and then you go for the surgery. Your recovery path is very, very good. Immediately after surgery, women are advised not to lift huge 20 kilos of weight because the area which has been operated is empty. We don't want the intestines to come down and drop down to the vagina, what we call vault prolapse. So lifting weights, pushing weights, climbing 10 to 15 floors in a row, all these should not be done in the immediate post-op period. Once 1 month is transpired, they can slowly bounce back to their routine activity. Sexual activity after intercourse is generally refrained from for 4 to 6 weeks because the area of the vagina which has been sutured should not get traumatized, and hence we tell women after surgery to abstain from intercourse for at least 6 to 8 weeks. So these are important do's and don'ts which women need to know. So when we remove the uterus, do we remove the ovaries or do we leave them behind? The general consensus is we don't remove the ovaries unless the woman is well after menopause. If we are doing a surgery for a woman under 45 or under 50 as well, we tend to leave the ovaries because ovaries are the seat of manufacturing of hormones and we don't remove. But in case the ovary is harboring some disease, there are some cysts, there is some endometriotic process going in there, or there are huge tumors in the ovary, then one may have to resort to removal of the ovary as well. Usually, the ovaries are left behind and they tend to continue to manufacture hormones for some time. Very rarely, women who have their ovaries retained after uterus removal may develop some cyst in the ovary, and very, very rarely, some may have to subject themselves to another surgery to remove this cyst. Yet, we tend to counsel our women and tend to keep the ovaries behind because keeping the ovaries behind can get their female hormones which can keep their heart, mind, and mood healthy. So for now, I think I have almost touched upon reasonably the indications, the way the procedure can be done, and the post-op care one needs to take after surgery. There is also another procedure of a vaginal hysterectomy, which I intentionally kept it for last. Now, vaginal hysterectomy is a procedure we do, especially when the uterus has descended down. In women who've had multiple deliveries, if their after menopause, the muscles lose its tensile strength and the uterus tends to prolapse down. In such women, we don't need to do any laparoscopy or even any abdominal incisions. We tend to operate completely from below. This is called a vaginal hysterectomy. This is a very efficient technique, and women from vaginal hysterectomy can recover as fast as even robotic hysterectomy because there is no cut on the abdomen at all, no 1 centimeter, zero point 0.5 centimeter cut at all. Everything is done from below, and the stitches are all deep inside the vagina. So this is a procedure we resort to women, especially if they have prolapse, and in some women who have delivered normal deliveries and their uterus is small size, we can still try a vaginal approach and remove the uterus from below. So these are all the ways and means of removing the uterus. For now, I'm hoping that I have covered more or less everything about hysterectomy. I would be happy to take any questions about this. Thank you. So, whenever a lady is undergoing a surgery, if it is a laparoscopy or a robotic surgery, generally after the surgery, the patient remains in the hospital for about 48 hours. Within 48 hours, they bounce back to their normal diet and activity, and most women are discharged within 48 hours after a minimal access procedure like a robotic or a laparoscopic surgery. But if an abdominal hysterectomy where a big incision is done, some people tend to stay longer. And of course, very rarely, if any complications happen, like injury to neighboring organs, etc., thankfully it is very, very rare, then the stay in the hospital may get prolonged. Otherwise, by and large, most women tend to get discharged within 48 hours of stay after a minimal access hysterectomy procedure. Yeah, I think I covered the risk associated with hysterectomy in my talk. I talked about the surgical risks like infection, injury to neighboring organs, bleeding, and blood clot formation and anesthesia complications. I just talked about it in detail during my talk. So these are primarily the risks associated with hysterectomy. Yeah, so generally, while removing the uterus, we remove the uterus and the fallopian tubes. The fallopian tubes are mainly the organs which carry which make the meeting point of the eggs and sperms. So when the uterus is removed, we invariably remove the fallopian tubes because fallopian tube can harbor cancer in the future. So we generally remove the tubes nowadays for all women who have removal of the uterus. Along with that, we remove the cervix, which is the part of the uterus which contributes towards labor. So this is generally the norm. We remove the uterus, we remove the tubes, and we remove the cervix. In certain conditions, we may have to remove extra things. So what are the other extra things? If a lady is having endometriosis or if she is having some ovarian tumor, along with this, we may have to remove one or both ovaries. If she is having something like a cancer within the lining of the uterus, we may have to remove a little bit more of the vagina, what we call the upper one third of the vagina, we may have to remove. If she is having cancer of the cervix, we may have to remove the lymph nodes which are far away, what we call retroperitoneal lymph node dissection, we may have to do. We may have to take a higher cuff of vagina to ensure that the removal has been complete. So these are the extra things we may have to remove depending on a case to case basis. So the different routes of hysterectomy surgery we have already talked on. One of them is the vaginal route where it is removed from below. Then there's the abdominal route where an incision is made like a big scar on the uterus, and then we remove the uterus from a big incision. Then it comes to the laparoscopic procedure where we put a laparoscope and do keyhole surgery. Then is the novel technology of robotic surgery, which is akin to laparoscopy, but the technology of the robotic makes it very comfortable, and the risks and complications are far more reduced with the robotic technology. If a hysterectomy is done and the cervix is completely removed, you don't need to get a pap smear done. Pap smear is a screening test for cervical cancer, and one may have to do a pap smear only if the cervix is retained. Those hysterectomies are called subtotal hysterectomies, where cervix is not removed. Why do people do uterus removal without removal of the cervix? In some people, the cervix is stuck to neighboring organs because of previous cesarean sections. Then some people leave the cervix behind. In such women, we may have to do a pap smear. Very rarely, if you are doing removal of the uterus for an early stage of cervical cancer, then also you may have to do a pap smear of the vault just to ensure that whatever procedure you have done is complete and final. Otherwise, most women who have a complete total hysterectomy where the cervix is removed, you don't need to subject yourself for a pap smear because cervix is completely removed, so there's no need to do a pap smear. Yeah, so now after removing the uterus, how does one plan the support of the remaining vagina? Is a very good question. Now, the uterus is supported by multiple ligaments and fibrous bands which help to keep the uterus in place. In fact, the uterus is in such a strategic location that if the uterus is removed, the intestines will quickly come and occupy that area. So, when you remove the uterus, that void is occupied by the intestines. And the intestines are not coming out of the vagina because of the vaginal muscular support which is there. In women who have a very weak vaginal floor or the pelvic floor, after repeated vaginal deliveries, they can have a condition called wall prolapse where the vagina will come out and then the intestines will begin to push the vagina further downwards. This condition is called wall prolapse. Now, when you do a vaginal hysterectomy, you are pulling the tissue from below. There is a much higher chance of wall prolapse. Hence, now vaginal hysterectomy is going back in the back seat only because the incidence of wall prolapse is a little higher. So, when we are doing laparoscopy and robotic surgery, we are conserving one very important ligament called the uterosacral ligament. By conserving the uterosacral ligament, the strength of the vagina is maintained, so much so that after minimal access robotic and laparoscopic surgery, the chance of wall prolapse is very, very minimal. Because in this procedure, we have a technique of retaining the uterosacrals, which will keep the vaginal tensile strength and turgor so much so that the wall prolapse doesn't happen. Also, sometimes we take a special stitch called a vault suspension where we keep the vaginal, the sutured vagina, we suture it to the angles of the uterosacral so that it remains tugged up. Also, we advise women not to lift weights, not to push weights, because if they have a weak muscle floor, the pelvic muscle floor, there can be a chance of wall prolapse. So, what is the complication rate post hysterectomy? If I have to talk about complication rate, I'll have to talk about each of the complications. Now, the incidence of infections after hysterectomy is probably 0.1 to 1%. The incidence of injury to neighboring organs, such as the urinary bladder, is supposed to be around zero point 0.3 to 1%. Depends on the case to case basis. If a lady has had multiple cesarean sections, there's a slightly higher chance of injury to the urinary bladder. Similarly, injury to the intestines can also happen. It depends on the case to case basis. So that can be to the tune of zero point 0.4 to 0.6%. So most of these complications are very minimalistic, but in certain cases with endometriosis, the complications rates can exponentially rise because endometriosis is a condition where the uterus gets densely stuck to neighboring organs. So then the complications rate can exponentially increase. Otherwise, in women who don't have endometriosis, who don't have previous scars, the chances of injury to neighboring organs is probably zero point 0.3 to 0.4%. And the infection rates are as less as 1%. And the chances of landing up with blood transfusion with the present current technology of minimal access is also very, very minimal. So, I will just like to summarize what all we discussed today. Hysterectomy is a major surgery, but thankfully, with minimal access techniques, it has become far more simpler and the recovery path has become very fast. With robotic technology, the incidence of risks and complications have reduced remarkably, and also the recovery path has been very, very good. And before one embarks on hysterectomy, one should weigh all the possible options which are available and try each of them if accessible to them or if applicable to them. And only when these conservative options don't work, they should think about it, plan it, and then go ahead with surgery. Never rush a surgery like a hysterectomy, then your recovery path can be far more longer. So I wish all women listening to this a very good menstrual health, and I hope you have a healthy life ahead. Thank you very much.